Okay, we are going to do an interesting case of a huge tortuosity of the abdominal aorta, the TAVI case, probably by axillary approach. And I will ask Dr. Kuzov now to present the case. Please, Dr. Kuzov.
Hello, guys. The next clinical scenario will be very complicated. It's above TAVI implantation in extremely angulated infrarenal aortic segment. It will be presented by our invasive cardiologists, Professor Petrov and Docent Stankov. It's all about a 76-year-old woman. She's complaining of chest discomfort, tiredness, and dizziness. She's with well-known aortic stenosis, and it was followed in the last 4 years. She's having intermittent right bundle branch block and left anterior fascicular block. She didn't have any obstructive coronary artery disease. Also, we noticed that she's having extremely angulated infrarenal segment of the abdominal aorta. Also, she's with extreme kyphoscoliosis and compression fracture of L3 vertebra. She's after total hysterectomy and polypectomy of the colon. Her status, it's she's 150 in height and only 45 kilos. She's in forced range of motion because of the hyperflexion of the lumbar segment, with the blood pressure within the normal range, and her limbs are within the preserved pulsations. From the ECG, as I already told, she's with intermittent right bundle block and left anterior fascicular block. From the echo, with extremely severe aortic stenosis with preserved ejection fraction, the gradients are 90/55. The AVA is 0.5 squared centimeters, with normal right side of the heart. This is the ECG, as I already mentioned. Those are the gradients from echo with AVA. Also, the calcification of the aortic valve is prolonged to the aortic root. This is the calcium over the non-coronary and right cusp of the valve. And from the CT aortogram, her calcium score is above 4,000. So I already told you that there is adhesion between the non-coronary and the right aortic leaflet. And now you're able to see the extreme tortuosity of the aorta with, I would say, double arch of the aorta in the infrarenal segment. It's enlarged here. This shows us the kyphoscoliosis of the vertebral segment of the woman, and basically when she's ambulating through her everyday life, she's bent over. According to the guideline, there are several different access points. Our colleagues today will choose transsubclavian one because of the extremely tortuosity of the abdominal segment, and our plan of treatment it's within the subclavian artery on the left side, the right cubital vein, the right radial artery. The valve that they are gonna use is the core valve Evolut Pro, 26 millimeters, prostyle as a closure device, and it will be a totally endovascular management.
Thank you, Dr. Kuzov. Do you have any comments or questions, dear colleagues?
I was
Professor
just
Vasiliev?
wondering how you compensate to do something insane during the last case, but now...
I cannot hear you very well, unfortunately.
Probably this is not bad.
Yes, now I hear you.
Okay. Ivo, probably we will switch to George Sianos to give his talk.
Okay.
And
I agree.
work quietly. We saw your case. It's very tough to be done.
It's a very tough, tiny, small lady.
So, okay, work quietly. Do not rush. We have enough time for the live transmission.
Excellent.
So,
okay, we are going to try to register all the steps in order to show you after that. Okay, thank you.
Let's switch to George. Hello, George.
Hello everyone. We are also preparing here for a live case. We have a very nice CT of the right coronary. I'll just try within 5-10 minutes maximum to update you a little bit about some aspects of the chronic total occlusions. And as you see here, single wire and parallel wire techniques were already established since many years, from the beginning of interventions to the early 2000s. And then imaging and the subintimal techniques with the STAR came in 2004. And since then, there was a lot of stagnation for many years with inferior success rates. And you see here registries that they have been published until the 2005. And this is a landmark. And you see that the success rate didn't exceed 70% in majority of the cases. So what happened and what really revolutionized the field to be standing here today with many options and much higher success rates in the CTO-PCI was the advent of the retrograde techniques in 2005, pioneered by the Japanese, and the subintimal connection techniques, or what we call more profoundly the dissection reentry, that they were introduced in subtilities from 2008 and they're evolving up to 2013. And I'm going to present you the latest of that. And we know very well that all of these, as we speak of today, they are not separate techniques. In the past, we were doing repeat procedures, initially trying antegrade, then retrograde and dissection reentry. But for the modern day CTO, PCI, all of these things, they have to come together in one single procedure, shifting fast the mindset from one technique to another. The milestones in the CTO PCI accepted techniques had to do also with the hardware. And you see here a table published a few years ago, and nothing much changed since then, but this was enough. The coatings with the polymeric and the hydrophilic since the early days, the incremental tip load, the taper tip design, the combination of the tapering with hydrophilic coating with the tip stiffness more than 9 grams. And then we have all these kind of combination into the lower range tip stiffness, then less than 1 gram with the Asahi Fielder XT. In 2010, 2011, the composite core technologies with the Sion and then the Fielder XT and XTR came. And the last big advancement was the Gaia family, which is the combination of composite core, polymeric and hydrophilic coatings into the what we call middle stiff range between 1 and 6 grams. So you see here, without getting into the very detail about what is a composite core wire, essentially it's an additional coil next to the core of the wire that essentially what does is that it has the capacity essentially to transform the one-to-one whatever you retain in your hands, it has to be transferred to the tip of the wire, and also the shape retention of these wires has been greatly enhanced. Here, and I'm not going to insist more, you see here we went also from the single wire to the wire rope, and this actually revolutionized even further from the Act 1 construction, as I said, with a composite core that you create one single wire from S-to-wire rope with wires that are much smaller than this wire. And these add more characteristics to the one that were used from the composite core. And this is called X-strand wire with a multi-wire rope coil. So the wires in the CTO PCI has dramatically evolved, and this affects these wires actually reflecting what I'm not sure if it's available in Europe, but the Gaia X family. And we shifted from the passive wire control with soft wires that they are less than 1 gram as the Fielder XTA and XTR to wires of intermediate stiffness that they are active wire control, and especially the Gaia family. And these wires actually are accounting for more than 50% of success rates. These wires are accounting for around 20-25%. And we have the classical stiff wires like the Confianza Pro and the Progress 200 and other wires now that are available in the field that essentially are necessary in less than 10% of the cases when you really have to have a penetration of hard tissue and especially calcified tissue. And most of these, they're not wires that work only by themselves, but most of the cases we have to combine all of these at certain parts of the procedures. The other big advancement, and again, I will not stay into the very details, is the microcatheters that they have tremendously evolved since the fine crosser was available from the very beginning, and then we have the Corsair that came later. And now you see that there is a combination of more than 20-25 microcatheters available. But a gross classification will be to big supportive microcatheters, to intermediate and smaller microcatheters. And then you have to have the angulated, the dual lumen microcatheters, from the single dual lumen to the true dual lumen microcatheters, just like the Recross. We have 5-6 of them. And then we have flag modification microcatheters, just like the Tornus, that is not anymore in use in the Turnpike Gold. Referring now to the software or to the techniques, we have the wire-based and the dissection-based techniques. The STAR, as I told you, was the beginning of the dissection re-entry techniques, and that has been refined to the mini-STAR and the limited antegrade subintimal tracking. And then the wire-based, which was essentially the crossboss device that came as a niche into the early days of CTO PCI after 2012, 2013. It has still its role and up to the latest antegrade fenestration reentry techniques, and I'm going to show you some examples. What you hear is the classical cornerstone technique that everybody has to have in its armamentarium is the parallel wire technique. You see here an occlusion of the LAD. The double injection is another rule that anymore it's, especially after the implementation of the retrograde technique, that it is not to be missed. And you see here that the first wire, which is a Fielder XT, goes slightly subintimal. We don't manipulate too much. Essentially, you just remove the microcatheter, you use it again, you take a stiffer wire. That's the principle. And this small difference, it's the difference between success and failure. And you see here how a parallel wire technique, fast and reliably, in combination with retrograde contrast injections, they guaranteed success in this case. Here I'm going to show you a case of an ADR device-based. So we still evolve on the antegrade techniques only. And you see here what we do is that essentially in cases like that, we try to do antegrade tracking as much as we can. We go to the subintimal space. Then essentially what you do is that by using knuckle wire, which is a wire-based technique, we go close to the distal cap, and then you see that we're reaching the distal part of the CTO. And what you do is that you use this special device for reentry that has two perpendicular lumens. And essentially by the puncturing initially with a stiff wire, essentially you're targeting the true lumen. You have to use specific projection in order to make sure that you're puncturing to the right side and not away from the lumen. And as you can appreciate here, there is a redirection of the wire from the subintimal space to the distal true lumen. And you get this kind of final and geographic result. The new thing that it's in the subintimal connection techniques is the antegrade fenestration reentry technique. I'll show you a case here, a CTO of the right coronary artery. Not very attractive for the intimal tracking because of the bridging collaterals. Essentially what you do, and the collaterals are there, but quite tortuous. What you do in this case is you want to reach the distal cap, and you do that safely by using wire-based ADR. You see the knuckle wire reaches the distal cap. You advance the microcatheter, and then you insert a device that it's a dual lumen microcatheter that has capacity of dilating. You dilate distal cap, the distal cap, and you create cracks in between the intimal and the subintimal and the distal true lumen, and the soft wire is really being advanced. So essentially, it's a modification of all of these techniques that you combine wires with balloon dilatations, and that is the final result that you're achieving there. So dilating the distal cap is the key point here. And you have to be using for the reentry wires that are softer, not to be able to extend the subintimal connections. For the retrogrades, I mean, it's well now established, the reverse car, the car technique from 2005 from Japanese. You dilate distally and then you make space for your antegrade wires to reach the distal true lumen with many steps of them. The simplest of these techniques is just a retrograde wire crossing, just like this case of CTO of the LAD in combination with left main. And you see here that there is an essentially retrograde axis, primarily retrograde. This is a calcified CTO. And what happened here, as you see, we're pushing the microcatheter. The wire buckles a little bit, and then you will see that after reinstation of the retrograde gears, the wire just crossing into the CTO and reaches the circumflex, and then it's being redirected to the left main. And essentially, that's the final result. That's the simplest of the retrograde techniques, the retrograde wire crossing. The most complex of them is the reverse cart technique. You see here one case of right coronary CTO. Retrograde access through epicardial collaterals. You reach the distal true lumen with the microcatheters, and what is going on is that your retrograde wire goes subintimally, and what you do afterwards is that because the retrograde microcatheters don't have any more penetration capacity, that's why we shift it into the field of reverse cart. You see the antegrade wire, the two wires are coming together. You dilate, as you can appreciate here, and then your retrograde wire shifts into the antegrade catheter. Hopefully we'll be able to demonstrate to you a procedure like that today if the antegrade doesn't work. Then you externalize the wire and you are achieving a result like that. So this is the subintimal retrograde dissection reentry techniques. And one modification of this is the use of doing this procedure, especially when you're doing LADs or CTOs close to the left main, as in this case, it was a Lima failure in a young guy. That was done a few years ago here in Bulgaria. And antegrade attempt has been failed for the first time, for the third time. I'm sorry, I don't know what happened to this. Anyway, and then you see here that the parallel wire technique has failed in this case also. So what we did is that we went through the vein graft and the right coronary artery retrograde in this case, through this epicardial collateral to the distal LAD. We're able to achieve retrograde access, and I just want to focus on the part that you see that we are dilating while advancing a guiding catheter extension, and then the retrograde wire targets this guiding catheter extension in order to be able to achieve the retrograde procedure. So this is the latest and the most used technique into the retrogrades, and you see here the final result in this case. So what I want to summarize is that there was a lot of confusion over the years, and we standardized anymore in the antegrade dissection and retrograde dissection reentry techniques and wire escalation antegrade and retrograde. That was a big step in order to be able to speak the same language. What you see here in the contemporary CTO techniques, there have been many algorithms that have been invented by different societies. The American hybrid algorithm. This is the European algorithm. It's not easy, but it's a kind of a roadmap as how you have to teach the younger generation. There are global algorithms also. People have to follow that. But what I always say that the CTO-PCI was an initial step in order to achieve complete revascularization in patients that they don't have only occluded coronary arteries, but they have hemodynamic compromise and comorbidities, which is the so-called CHIP concept. And CTO is at the top of the pyramid, including the left ventricular support, the calcium modification, the left main, the bifurcations. And always, to me at least, as the evolution of all of these things, the CTO PCI actually was a revolution that showed the evolution in techniques, and many of the lessons that learned from the CTO PCI, they have been implemented even in the non-occlusive coronary artery disease, and operators that they don't follow CTO PCI, they have implemented these techniques in order to be able to make the complex procedures more efficient and more successful. Thank you.
Thank you, George. Because for the sake of time, we have to proceed. I would like to ask you just to join to the team in the cath lab, just for the case. As far as I know, you will be the operator.
We have a patient on the table, so we're ready to
so
move
maybe during the case we will discuss.
Go to the rest of the lab centers and we will come back to you soon. Thank you.
Okay, thank you so much. Може би да се върнем пак в Сити, защото поне доколкото виждам тук, другите са в процес на подготовка още. Да се върнем, не, в болница Чирков са готови.
Okay.
Нека в болница Чирков да се върнем обратно.
Чуваме ли се?
Да. Диана, чуваме.
Hi. Because we advanced, we have a case who Dr. Angel will present. Very short, Dr. Angel.
Yes, please.
I'll try to. Good afternoon, colleagues. I'm going to present you a clinical case of 74 years of age male with heart failure third grade by NIHA with comorbidities, arterial hypertension, dyslipidemia, chronic kidney disease, and severe immobilization due to neurodegeneration. From the echo, you can appreciate left ventricular hypertrophy, preserved ejection fraction with mild mitral regurgitation, severe aortic stenosis with fibrocalcinosis of the leaflets, which they seem bicuspid with raphe between left coronary and right coronary leaflet. Clinical laboratory, you may appreciate increased levels of creatinine, eGFR 33.4. We discussed the patient on the heart team. According to the heart team, we have relatively low STI score with increased Euroscore 2, but due to the chronic kidney disease and the immobilization of the patient, we decided to perform TAVI. Indeed, the bicuspid aortic valve is more favorable for surgical aortic valve replacement, but according to the TVT registry, the bicuspid aortic stenosis treated with Evolut R Pro in the US TVT registry, we have patients with average age of 73, 30-day death, and is 2.6 versus 1.7 if you compare it to the patients with tricuspid aortic stenosis, and 30-day stroke rate is 3.4 for 2.7, which is non-significant. So the treating of severe aortic stenosis in patients with bicuspid aortic valve is not more risky for, according to the mortality and stroke, compared to the patients with aortic stenosis with tricuspid aortic valve. So we decided to perform the procedure, and due to the CT, you may appreciate the severe calcification on the aortic valve. Peripheral arteries are a bit tortuous, but with really nice size, no severe stenosis. So we decided to perform procedure through the left femoral artery. From here, you may see the calcification, the raphe between the right and the left coronary cusps, pretty high position of the left and right coronary arteries. According to the sizes, we decided to, with the patients with bicuspid aortic valve, it's a bit tricky to decide the size of the valve because firstly, we usually use the size of the aortic annulus, but it's important to assess also the intercommissural distance on the supraannular distance. We measure it 4 millimeters above the annulus, 5 and 8 millimeters. So we may create better understanding on the anatomy of the bicuspid aortic valve, because it's a bit different compared to the tricuspid aortic stenosis, because the most stenotic part is not the aortic annulus, but it's a bit higher. According to the classification of the aortic valve, bicuspid aortic valve, we may put the patient in type 1 severs, which is really useful because it's easy to be used and widely adopted, but there is a lack of detail and does not define all bicuspid aortic valve subtypes. So according to the Bavard registry, comparing the aortic annulus and the size of the intercommissural distance, we may separate the patients in 3 groups, like a tube when the size of the annulus and the ICD is the same, flare when the annulus is smaller than the ICD, and tapered when the annulus is higher than the ICD. Our patient's sizes was is close to flare, but the difference between the ICD and the annulus is 0.6 millimeters. It's not that much, but still the size is in the 34 range of the valve. Also, we have to appreciate the severity of the calcinosis, because patients with severe calcinosis on the raphe are the patients with highest with the highest death rate in the long term when they're followed up. So the most problematic things here are going to be the ellipsoid form, the highest point of coaptation of the leaflets, asymmetric calcification, the higher calcium load, and dilated horizontal aorta. So we are going to use safe expandable Evolut Pro because of the better radial force and because of the outer skirt, which is going to reduce the incidence of
Yes, Dr. Angelov, maybe we can continue the discussion while we watch your case.
That was
Proceed
very
because-
short presentation.
Okay, I will show what we did. So the first step, you usually use roadmap to femoral puncture. So you can see the very tutorial segment of the aortoiliac segment. So we decide to go to the left femoral artery. We pass the valve with the straight wire, change it with Wonderquist because of the tortuosity of aorta, and did predilation with balloon 2440. You can see the angiography. The balloon is quite good for the annulus. So we next step is to go with the valve system. We check the valve; it's okay as a crimping. So we are going to remove the 14 introducer from the femoral artery. So and
We will now go with
valve system.
Can you explain to the audience here why you chose the Evolut valve?
We choose the valve because the size of the size of the annulus complex is quite big. This first one, the second one is we have patients with bicuspid pathology, and we need to use system which is with a straight radial force for the to get good hemodynamic. And because of there's a lot of data from STS from the good results with Evolute our system.
Yes, and here we have to say that it's an Evolute Pro.
I have
Pro Plus.
Pro Plus is the last generation of the Evolute system with the additional skirts, which is prevent the aortic regurg in these patients. So, dilator, please.
Окей. Вадиме се. 14 дилататор дайте. Може и 16. Ама дайте 14 пъти. След нея ви му дочи само.
Okay, we will leave you to work here, and let's go to CT. I saw that Professor Petrov was placing the...
Удача.
Can we switch to CT? Okay,
Давай напред.
so there... Hello, Ivo, again.
Давай да действа.
Hello, Ivo.
Hello.
So, tell us what you have done up to now.
Okay, it's a very tough case by anatomical point of view. As you saw, it's a tiny lady, 40 kilos, with a huge tortuosity of the abdominal aorta. It's absolutely impossible to cross the abdominal aorta with the delivery system. And let's go since the beginning of the X-ray. And I will show you also the room. So by the camera, I will show you that the lady is on the opposite side. So we have her head on the right. So her head is here, and over there are the legs. So in order to have some commodity for the implantation. So this is a very interesting cannulation from the right radial, cannulation of the left subclavian artery, you see, with the Simmons catheter. Why? In order to opacify the left subclavian and axillar artery. In fact, our access, our target access, our aim is not to puncture the subclavian, but to puncture the axillar artery because it's easier to be reached in case of complication. And we have measured the subclavian and the axillar artery, and because we are going to implant a 26 number 26 valve, the subclavian is big enough to accommodate the delivery system. Let's go next. So this is the position of the pigtail, and this is the position again. You see, this is the opacification of the left axillar artery. Next, please. And we put through the sheet, through the Simmons catheter, we put a 0.14 coronary wire. And in fact, we punctured with aiming, with pointing with the needle. We were pointing the 0.14 wire put into the axillar artery. So far, so good. So we have pre-dilated already. Go next. Go next. Yeah. Okay. This is you have to have some notion about the strange anatomy, and you see there is a more or less horizontal aorta, and it's change anatomy because the usual projections for cusp overlap and tricusp view were not working. Go next, and we have crossed. Okay, next. Hopefully, fortunately, the left ventricle is not too small. We had some suspicion that the ventricle is extremely small, but fortunately it's not so extremely small. Next, please. Okay, this is the big sheet, the 14 French sheet position. Now you are going to see the balloon coming from the axillary artery. This is the balloon. Next, please. And under rapid pacing, we have inflated, and yeah, this is the injection before ballooning. This is the balloon predilation. Okay, and in fact, we finally succeeded to find some kind of three-cusp view. It's a very deep spider view, some kind of 31 LAO and 22 Coldal. So we have to work mainly in this position, and we are going to try to align the tip of the ampoule of the delivery system with the pigtail already in a good position of this projection. Some questions, remarks?
Clear enough. Oh, Nikki, Dr. Stoyanov. Does the patient is under general anesthesia?
No, not at all. She's under conscious sedation. She's doing very well, excellent pressure, 100% saturation, any problem to that moment. And she's absolutely calm without any complaints.
What kind of a valve are you going to implant, Ivo?
What kind?
Of a valve. What is the valve?
It's this is the Evolut Pro 26.
Because I think here it's more of a case for an Edwards valve because of the horizontal aorta and because of the double, the opportunity to really be coaxial.
Yeah, we have discussed also even accurate now because it's a little shorter, or Sapien 3, absolutely right. But we have measured all the angulations and all the rest, and we have decided that it's possible. By the way, the live view is showing that the aorta is not so short, and you see it's not so horizontal. It's slightly horizontal, but it's definitely possible. It's not off-label, so the implantation of Evolut is not off-label. Okay, and we advance it. We are going to proceed.
Because Tokuda, they are ready to present their case, we will switch there and then we will go back to you. Okay.
Excellent.
Okay,
We are proceeding with the valve.
Colleagues from Tokuda Hospital, they want to present their case.
Take the wire out.
Valery, you are online.
So we are working on this CPO. Now we
Let's present the case.
Dr. Ramf is going to present the case.
Okay. Hello, everyone. Let me present the third case from our center. It's about 60 years old male patient with high-grade stable angina. The patient is with three-vessel disease, and this year it was performed PCIF LAD with implantation one drug-eluting stent. The patient is with typical risk factors for cardiovascular disease. You can see optimal blood pressure, heart rate. From the ECG, we have sinus rhythm with Q waves in inferior leads and STT changes in V3, V6. From echo, you can appreciate mildly reduced left ventricular function with basal inferior and lateral hypokinesia. Here you can see the angio, the coronary anatomy, proximal occlusion of circumflex artery with distal collateral filling, and proximal occlusion of the right, also with retrograde filling. Here you can appreciate some connections. patent stent of LED in mid-segment. In this patient, we performed stress echo, and we have 4 segments inducible ischemia in the right coronary artery and 2 in the circumflex artery. That's the case.
So, what is your plan at the moment? What do you think? I see you go retrogradely. Okay.
No, but I mean, before we reach that point, we would like to show you what the experience that we had from this procedure. So this is the films that we have now with combined left and right injections. Our setup is here as right radial, and we have an AL1 into the right coronary artery, and we have an EBU 3.5, 7 French from the right groin, from the right femoral. Here is a combined injection, left and right, as you can appreciate. The right is a very big vessel. And what we see here is that there is a blunt cap. And it's a very big vessel. When we say blunt, blunt. And there is a branch that is a little bit more proximal that doesn't affect the proximal cap. So here is a cranial projection. You can appreciate it's a good projection. There is the first marginal branch, the first septal branch that provides good collateral to the distal PDA, and there is a second branch. I think that's one of the best projections that we have. Let me just put that as a reference for us. And let's go to this projection. We are going to work there. You see also the circ is occluded, but it's a small vessel. So what we faced here, we did some additional filming to clarify better the collateral circulation. Definitely it's well developed, many septal collaterals. The feeling was that blunt caps, generally speaking, is not easy to puncture, especially when it's proximal and the vessel is big. Here you see a Gaia 3 wire that the problem is that you see it because the cap might not be extremely calcified, but definitely the vessel is big and wires with a short tip like the Gaia 3rd, you can appreciate that we fail completely to puncture. There was no way that we can puncture there. This is, we tried with a Gaia 3, we tried with a Gladius EX, which is a 3-glad wire polymeric, and we went with a wire like the Confianza Pro, all these within the first 3-4 minutes. And you see that the Confianza Pro made a progress. We didn't know, of course, where, but you see a puncture of the proximal cap. And when we do retrograde injection, we can see that it is definitely completely into any wrong direction. Based on that, I didn't insist more, or I thought that the occlusion is not very long. We have good collateral circulation. That's why essentially we shifted now to the retrograde approach without losing much time. I don't know if your comments or what would be contrast your approach here.
When you are in retro, wouldn't you prepare the antegrade vessel first? A little bit more time.
Yeah, I mean, we tried as much as we could, and you saw that we used stiff wires. We can do parallel wiring there, but in my view, I had quite difficult problems to have a better clarification of where I have to puncture it. It's completely blunt cap. The collateral is, in this one especially, is not very clear. So we can spend more time on the antegrade attempt, but because the occlusion is very short, I have the feeling that if by any means we achieve to go retrogradely fast and reliably and get access there, the ischemic time will be anyway quite short. So in that respect, my appreciation about these things is, as I told you, is not very much on the aspect of delaying too much. Fluorostore this. You saw that we had an easy crossing. We are already there, as you can appreciate.
Can you give us some insight about the microcatheter and the wire you are using now?
The microcatheter is the Turpike LP. is let's make a film from that, is a Corsair XS Pro, and the wire is just a Xeon black wire. That's what I'm saying is, when you're implementing retrograde techniques, when the chances or the prospects of the retrograde wiring are as good as this one, I think you should not hesitate. Let's see how this microcatheter is going to track. It was septal surfing, and I have the feeling that this was a little bit of a short microcatheter, but I see that the guiding catheter, but I see that the catheter is tracking very nicely. Save that. That's another proof that when you have a good selection of the technique and when you have the anatomy, you don't need really to struggle too much. Just go and follow the procedure. Of course, retrograde techniques, we know that they're related to higher complications, but compared to the other techniques, but experience is a buffering parameter also. We have changed completely the game in 10 seconds for this case, the perspective of that. And I can do much safer antegrade attempt now, should that be necessary. You understand what I mean?
Yeah, I totally agree.
I see where I'm going. We have a very nice, marker anymore.
So you know where to puncture antegradely.
We know, but you see also what is going on, because Dr. Gelef made a very nice comment before, which is very relevant now, and I'm going to show what we mean. Is that I have underestimated that, to be honest with you, but I think this is, Dr. Gelef, why don't you comment about what you were saying a little bit in this projection? If you see deeper here, let me just go a little bit back. You see that retrogradely, there is one channel that goes up, and that was my feeling, but
I think it's a branch. Because it is going beyond the proximal part. I mean, it is more proximal than the proximal part of the vessel. And this is misleading, but still we have what we discussed, George. Still we have this taper type of the retrograde.
This is, I think that your observation, because
of the distal cap,
I was planning to go retrograde.
If I may, just to make
was proven right,
very short.
But the observation of Dr. Gelef make me more conscious, because most of the time when I have this kind of feeling, I would have taken the Gladius now and go ahead without much attention. But before I do that now, I'm going to make a tip injection just to clarify the distal vessel.
It's Dobrin. Just a short comment. If at the beginning you made the ADO double injection, maybe it would be much more clear about this channel. Because for me, it seems, but I could be wrong, there is a high probability that probably I could be wrong, but in the small probability that there is a channel there, some probably know it, as I see now. Maybe the conclusion is these are the two planes, just there is a big kinking there at the site of occlusion. Because you see how they move in the different planes.
So you're absolutely right, and what we're going to do now, definitely this is a complex CTO, okay? When we were selecting the case, we were considering choosing a little bit of an easier case. We thought that there is some antegrade channel, but I see now that this CTO is a complex CTO.
Yeah, but this is easy for you, George. So you have a lot of collaterals, and you're George Tsianos, so this is a relevantly good case and good example for us here. So we want to learn from you. So, so thank you.
Made a very nice comment, because here, what he essentially said is that we have vessel ambiguity. So we don't really know where the occlusion is and what is the real track of this vessel. Yeah, and the way to do it, first of all, I will try for retrograde wiring just to see if it goes anywhere. And it's obvious, I don't know, I'm not sure, but let's see how this is going up.
Yeah, but you are in a good position now, so...
I'm not sure. I think
which wire is that? Which is
a little bit from the...
George, what is
the Gaia 3 from the right. Okay. I don't believe that as you see, all the wires, antegrade, were just following a little bit. Antegrade and retrograde are following the wrong pathway.
So that's the reason.
So I'll try to puncture in a different direction, finding resistance.
So that's
But
the reason.
nothing is easy here.
Yeah, I know, but that's the reason why you should knuckle somehow from somewhere, and the easiest part is now knuckling from antegrade. And you cannot do it retrogradely because you don't have good support, and you cannot puncture the cap there. But antegradely, you have the opportunity, I think, at least going a little bit into the proximal cup with your microcatheter, and then try to knuckle down with a soft wire. Then you know the course of the artery. I know it's not easy. I know that, of course, but you don't have good support there.
You're absolutely right. But I'm trying to see, as you see, I'm exploring different pathways. If I can guide the wire, and as you said, knuckling is an option here that we have to do it, and bilateral knuckling. But I will, in order to make sure that we're not going to have any course outside the vessel, but I'm trying now to find one way that I can puncture a little bit with more resistance. The wire is going up. That means that there are a lot of branches, but it's going strangely. Okay. You see in many different directions.
George, we'll leave you just to keep working quietly, and we will switch to Chirkov Clinic just to see, because they finished actually.
That's good. That's good. Thank you.
Their case, the final result.
Yeah.
Diana, you're online.
We have finished our patient just now, so we will show what we did. This is the position of the valve. You can see that the pigtail is the bottom of non-coronary sinus, which is the marker for the depth of the implantation. So we started to open the valve. Now we will check the position. You can see in this position, because of the calcium of the bottom of the non-coronary sinus, we are already on 2 millimeters depth. This is another position, tricast view. The depth is about 3 millimeters, and we decided to open the valve in this position. So let's go. You can see the release the valve, and after the remove the nose cone of the system, we will do the orthography next. This is orthography. You can see the huge aortic regurgitation. So after the removing of the Wunderquist, the aortic regurgitation is zero. So the valve is quite good open in two different projections. So we decide to finish the procedure. And next is called the femoral artery with Malta 18. And this is the final orthography. Okay. So,
okay, great.
That's all.
Okay. Okay, Shavket has a question, I see.
No. It's a great job. I'm just wondering what George is doing there. He is doing a phenomenal work there. So we are. I think we are done here.
Okay.
Yeah.
Good.
Thank you.
I don't know. The colleagues from City are not writing me out.
Now,
so let's go back to Tokuda, and I will check what is the situation in City.
I just want to know how he is going to puncture antegrately. So that's
We will see now. We have a better understanding of the. So we are wild. Interest.
So he is struggling there, and there is a good teaching point here, how he will puncture antegrately, and what kind of maneuvers he will do, what kind of techniques, what kind of moving the cap techniques he will use here, and it's important. I think this part is for me very interesting, at least.
I don't want to rush in more complex techniques of this kind until I exhaust my options.
Yeah.
So what you see here is that we are subintimally, but we are reasonably subintimally. And on that respect, I think that we, by this wiring as I'm having it now, we clarified a little bit the vessel course. As you can appreciate here, we're not too wrong. And I'm pretty sure I confirmed that in 3 different projections. I'm going to show you. This was caudal. This is cranial.
Is this still Gaia third?
This is the Gaia third, yes,
Okay.
because I was preparing for an Gladius, and I might try to do the re-entry. You see here in 3 different projections that none of these projections were too far. I'll try a little bit whether I can really make it, because this wire is not too bad. As you can see, we control that in 3 different projections, and it's looking like that it is quiet into the right direction. And I am trying to advance the microcatheter. I have some difficulties over there. You see that it is subintimal. It doesn't jump into the aorta.
Yeah. But you are in a very good position. So.
But we are in a very good position.
Yeah.
What I want to do here, I want to gain a little bit more microcatheter. I'm advancing the guiding catheter. I will try to advance the microcatheter if I can, but without losing the wire position. That's also another critical thing. And then maybe I'm able to re-enter, because I made an effort to go there, but the microcatheter is not easily following. You can appreciate that.
Yeah.
So in that direction, and you see that the wire is subintimal, so I lost what I had before, and it's not easy to regain, and this wire is not behaving. Actually, it was knuckling. So I will take now give me the Gladius. Let's see if the Gladius can make any chip success there. But you can see that we might be able to make a true wire crossing.
That was what Gaia.
I'm losing. I'm going to advance a little bit the possibility to get a little bit more microcatheter.
Yeah, you will kill the monster. We are sure of that. Just for curiosity, why in that subintimal position you had a good course and know where the vessel course is going? So why didn't you puncture antegrately? And
we will.
Yeah. We will. Okay. But you lost your position. So you wanted to go into the guiding catheter, and during that.
Yeah, I'm trying to.
Yeah, and
let me just see.
Okay,
Look at the difficulties that the guiding.
Yeah. Of course.
Microcatheter it has.
While they are.
So it didn't even puncture the distal cap.
Yeah,
So let me see if with this wire I can do something, and then we will start working on the grade.
Yeah.
Look at this position there. It's very strange for a microcatheter.
Just to see the guys from City, because they're till the end of their difficult case, just to see what they have done. Ivo, you're online.
Yeah, I'm listening to you. Okay. We are going to show you step by step what we have done. I will start from the behind. We have implanted the valve. I think this is the most important piece of news. Okay, this is the check of the valve for the symmetrical loading, and this is step by step on 2 steps. So we up to the click, we open the valve up to the click, go back 1. Okay, this is the check after the click. We were happy with the position. Go next. Go next. Go next. Yeah, this is the check. This is the check after the click. So, in fact, we stopped rapid pacing in order to check the position and hemodynamics and so on. And we were happy. It's some kind of position 1. And okay, go next. Go next. Previous. Okay, previous. Okay, this is the final implantation after the intermediate checking. The valve laid very nicely. It's a self-positionable, self-adjustable valve. So it was, you see, it opened very well symmetrically, despite of the slightly horizontal aorta. Next. And after removing very slowly, because in fact we have introduced just several centimeters of the sheath because the lady is very, very small, and even from the axillary artery, the distance to the valve is very, very small. And because of that, very carefully we removed the nose of the delivery system. And this is the first check in this position, into the left position. You see it's virtually zero PVL. Next, and we checked also in the other position, the right. And again, we have zero PVL. The arterial pressure now is 150/90. The lady is absolutely stable, 100 of saturation, and there is a small detail. The small detail is probably you remember from the presentation that the lady had left anterior bundle branch block and right bundle branch block, so bifascicular. And after the implantation, we were definitely very, very happy with that. We saw a short period of asystole. It was like a cold shower. And the electrode was escaped from the right ventricle, and we had to position very, very fastly from femoral approach. We positioned second electrode, and now she is practically totally dependent on the pacing. And it was expected, and probably she will need, of course we are going to wait till tomorrow, but probably she will need a permanent pacemaker. And that's it.
Ivo?
So I'm listening for you.
Ivo, sorry, it's Vasil. Do we see some bleeding from the axillary artery? Or?
Yes, there is a very small bleeding. We put prostyle, and in case we are going to reduce the arterial pressure. It's also important. And we have implanted also angioseal 8 French. There is by the way, for femoral approach, there is a trial in which routinely is used prostyle and angioseal. And we have some experience with this strategy. But now after reducing the arterial pressure, we are going to check again. And I mentioned in the beginning that absolutely by purpose we did axillary and not subclavian access in order to have easier compression and hemostasis, because the axillary artery of this lady is very close to the skin. So we are compressing a little now after the
So that was the second question. How effective is the compression in this area to block the leakage?
It's very efficient. It's very efficient because it's over the chest. It's over the chest. So we have very good basic tissues, firm basic tissue, and it's absolutely efficient.
Okay, and how long do you wait before you implant a permanent pacer?
At least 24 hours.
24.
At least 24 hours. I mentioned the valve is in a very high position, absolutely by purpose, exactly with this aim to reduce the probability for pacemaker implantation. You see in this projection, it's practically on position 0. And yeah, we'll see. We'll check tomorrow and we'll decide.
Because in this situation, it's a high risk of late block, which can be on the 3rd or 4th day. So usually what we do, we implant a pacer irrespective of the whether the patient regains the rhythm or not. But
very good note. Absolutely. Even in case of left bundle branch block, it's also elevated the probability for permanent AV block. But yeah, we'll see. We'll see. There are different scenarios. We are going to wait overnight, and probably tomorrow we are going to implant the pace. Okay.
So excellent case. Thank you so much.
Thank you.
Thank you.
Thank you.
Congratulations. So let's go back to Kuda.
Live.
Yes, you're live.
Contrast.
Valery?
Yeah.
George?
Okay. What happened is that as I was expecting, we left you here. It was obvious that with the guy we did a good progress into the right direction. When I'm always there, I never rush into complicating life. You have to get the maximum of what the procedure has to offer. So essentially because you can do proximal cap modification, you can do all of these techniques, they're quite complex. Anyway, I had the feeling that we had chances for retrograde wire crossing, and I changed the wire into an Gladius EX. And one of the things that you will see from the details, first of all, see the tracking. So it takes a 90 degrees bending before entering the proximal cap, and then you saw that we crossed into the aorta. I'll just leave it just for you to see how it's really working. It is not an instant tortuosity occlusion, in situ tortuosity, but the vessel is very big. It's 4.5, even bigger. And the proximal cap is quite tough, and you will see why I'm telling that. And now, when you finish the procedure, you understand the problems. You see the retrograde wire, it goes over there, and then it goes subintimal, you correct it, see how it tracks, and then you see this 90 degrees bending of the wire, and then it jumps, and it goes into the true lumen, and then goes to the aorta. Then we struggled, because I tried to push this wire into the guiding catheter, and it was impossible from what I know now. Here you see that I have it again. It was not easy to hear in subclavia. Anyway, what happened is that we tried to advance the microcatheter retrogradely, and it makes progress within the CTO, no doubt. You can see it here. And that's where we're sitting now, because the main issue here is that we have the wire into the ascending aorta, but the microcatheter is sitting there. First of all, I would like to show you one thing. See that one? You see that the crossing of the retrograde wire, it's completely in the inferior part of this, on the inferior rim of this right coronary. And if you do antegrade attempt, let me just see if I have to show you the wire crossing here. All the anterior crossing here, look at that. It was puncturing completely into the wrong direction. And that's exactly what I had in my mind when I was doing the antegrade. Because if your wire goes completely out, you saw that in the initial crossing, the wire crosses very, very close into this conus branch. As compared to this wire that you see here, where is the real crossing point? It's very close to that. So essentially in this very big vessel and a blunt cap, it's really difficult to go antegrade. And whenever you start doing, let's do antegrade work, let's not do antegrade work, and this and that, you can really make your life miserable. But we have a problem now that, first of all, I'm running out of, can you focus a little bit on my hands, please? I'm running out of microcatheter, that's point one. The second thing is that all the problem into the right in this occlusion was coming from two facts. First of all, that the vessel is big with a blunt camp, which I didn't know where to puncture it, and the fact also that this proximal cap is severely calcified. And you see that I'm running there, because now, if I'm able to cross this proximal cap, then essentially the procedure is finished, but I'm pushing this microcatheter as much as I can, and it is stacking this millimeter that it needs to jump in, and then we take a wire with a little bit of more bend in order to enter the antegrade microcatheter. I don't know if I made any progress now. Contrast? Maybe I did, I don't know. Yeah, I did. I think I did. So, yeah.
Your gladius is somewhere in subclavia.
Yeah, but I mean, I crossed now, save that.
No, I know, just because I missed the, yeah.
No, simply the wire over there.
Yeah,
you see that
okay.
when I was pushing the wire, it was going there in the aortic carotid. But I needed length. So essentially now, if I may say what is going on, I have the feeling, I hope that the wire is not subintimal. In a way, it looks like okay. Because the vessel is big, we have the microcatheter where it has to be. Let's go into different directions, because there is always a possibility, a small possibility, that we are subintimal and we're entering the aorta outside the true ostium. That possibility always exists. But I think we are not. Let's see a little bit here. Simply the vessel is too big. Look, where is the microcatheter? Anyway, it looks like that the microcatheter is into the right direction. So give me the run-through wire. I will remove this wire anymore. I don't want it, and I'll just make. No, it goes okay. So I'm pushing in and out. It goes okay. What does that mean? That means that we will see how we will make the connection now, because we have to enter the undergrade guide, and usually the undergrade guide is going to the wire. Let me push the amplats up, if I can. That's better. Or I exit it now. Contrast a little bit. We are okay. Give me the run through. You see that the catheter was typically sitting. The rule here is that the wire goes to, the guiding goes to the wire, not the wire to the guiding. When you have problems, I mean. Let's see now about a little bit this alignment on the guiding catheter, whether it will allow now wire that has changed now to a run through. We just need to re-enter. If we re-enter the guiding catheter, then it will be much easier. We will trap the wire, and we will externalize, and essentially the procedure is finished. So you see that we have this malalignment between the guiding. I'll push the guiding down. When we push the guiding down, it goes out of the ostium. And I will see whether I can target it by any means.
What about the guide extension?
Yeah, that would be also an option, but contrast a little bit. We will use, it's a matter of time now, just to align the two devices.
Yeah, no, see, you have now antegrade flow. That's good.
What I don't want to do is that I don't want to put this microcatheter back. This one I don't. So let me see if I can work more on the guiding and see if I can just push it in.
You have already created some space between two planes.
No,
so yeah, you will do it. Yeah.
This is just a matter of patience. And
but it was
a small movement.
Yeah,
give
but,
me 2.5 balloon.
Yeah, George, it was after giving contrast from antegrade. You created more fenestration, I think.
It's a matter of time. I mean, people are rushing, give me a snare, give me this, give me that. As you see, you align the devices, you do it nicely. The movements here are sub-0 millimeter. That's the key point, is that you have to do very fine movements. Control yourself, not to rush. You see here, we tried one more time. I could have pulled back the microcatheter and then run into problems. You do the correction a little bit. You work mainly on the guiding and less on the wire.
You see here, you give contrast and you reach the target vessel antegradely a little bit. I think that created some kind of fenestration, I don't know. And that's the reason maybe you are so easily go in.
What do you mean fenestration?
Yeah, you give contrast, you dissect it further with contrast antegradely.
To dissected what?
You created more fenestrations, I think, from different planes a little bit after giving contrast antegradely.
I don't think so, but anyway, it might be. It might be the point. I'm not sure whether it is the case, but this is too much of thinking for me. I just focus on where is that balloon?
But thank you very much for this nice demonstration. It was masterly done as always, so thank you very much. So the case is almost done here.
16. So we have some more aspects. I don't know if you have more. You see the balloon there, it's inflated. And over this balloon now I'm going to advance. I'm essentially run out of microcatheter completely. So I will just push the guiding catheter in the grade. He's a big patient.
George, sorry for interruption. I have to, we will still be online with you. But I want to make some administrative notes here. Just we will be online. I will interrupt you for 2 or 3 minutes.
No problem, no problem. The only thing I would like to show you now,
We are watching you all the time. Just I have to give several messages to audience. Мога ли да помоля, който си е платил членския внос, да вдигне ръка, член на дружеството? Добре, членския внос, който си е платил на дружеството, да. Добре, определено, така като гледам на око, мисля, че сме доста под половината от 184 члена на дружеството. За това обявявам началото на общото събрание сега, за да тече 1 час предизвестие за общото събрание, защото иначе ще трябва да чакаме много, така че сега е 17:20, т.е. в 18:20 можем да започнем общото събрание, за да не губим време, просто го обявявам сега, тъй като сме твърде малко. Ако някой все още е член на дружеството и не си е платил членския внос, моля да отиде да си го плати. Защото иначе няма да може да гласува, а кандидатите за нови членове, много ви моля да идете си напишете молбите. Okay, George, we are back to you.
Okay, focus on the hands of Dr. Gelef if we can, a little bit as a background.
Може ли да ни дадете камера към залата, освен да виждаме ангелото и операторите?
Can you see the hands of Dr. Gelef?
No, I just asked to have a second camera. Yeah. We have on the big screen behind us, but we don't have in front. Okay, we have.
Let me wire a little bit more,
okay,
Dr. Gelef, and then we go back. As Dr. Gelef is doing the externalization here, let's focus on that, and I will show to you what we did. So we have the Y connector, we have the needle, and Dr. Gelef has in his hands the RG3, and essentially the way to do the externalization is that you use the RG3, you insert it into the needle, and then essentially the externalization is finishing. Yes, Dr. Gelef doesn't come. Let's
let's.
We need double specs here. That's why I left the delicate part of this procedure. As far as Dr. Gelef is doing that, let me show you something. What you did, what you saw before, is we advanced
the pleasure of.
Yes, okay. Focus here, but what we did here, first of all, we crossed, and then as you see, advanced the retrograde microcatheter, and what we did, we put the microcatheter into the antegrade guiding, and we trapped the microcatheter with balloon. This is a 2.5 balloon to 1 atmosphere. What does that mean? First of all, it prevents the bleeding, because you see here, we have the Y connector out, and there is no bleeding. And the second thing, it stabilizes the microcatheter. So this is a trick that you have to do. Give me another run through, because we have to proceed now. So we have the externalized wire, as you can appreciate here. We have this wire which is externalized. I will advance a little bit more wire so we have more. And the next step is to retrieve the retrograde microcatheter. The way to do that safely, focus on my left main there. If I pull back the retrograde microcatheter, the antegrade guide, the retrograde guide might dive into the left main and might dissect. In the past, or even now, we are retrieving the retrograde microcatheter, the EBU, which I'm going to do, as you will appreciate here. No, don't do anything. Give me a wire. What we do mostly now, we take another wire and we put it around the sinuses, and essentially, as you will see, what does that is doing, because retrieving the retrograde microcatheter always carry the risk. So it goes to the left main. We don't want. First of all, you see here we go to the sinus, and what does that mean? That if you try to push now the guiding into the left main is not possible. So essentially, that you see it cannot go. That means that we are preventing the guiding catheter of entering the left main. and I can retrieve, deflate now. I hope you can see it clearly. I can retrieve my retrograde microcatheter without the risk that the guiding catheter will dive into the left main. That's it.
Yeah,
Okay.
a nice trick at least.
Yeah, that we learned a little bit as far as much you have to protect. So give me another 2.0 balloon now. I will dilate the occlusion. We reach the point of dilatation now. So more straightforward PCI. So you see that in this complex case, the retrograde techniques, never rush. That's at least my approach. That's my experience. Give me also an.
But you are fast. You are very fast. So I don't know.
Yeah, but rushing doesn't mean time.
Yeah.
Rushing means mental orientation. So never rush mentally. One other thing that you have to do here is that we put an torquer just in front of the retrograde microcatheter to prevent, because we're going to work on this RG3. If by any means you have difficulties during the procedure and you don't have the wire anchored, it might dive into the guiding, to the microcatheter, and you might have problems over there.
Or sometimes you lose the loose end, so you have always put the torquer there. So
exactly, that's exactly what we meant. And as you see, we always keep this wire outside the left main, just to make sure that it will not compromise. Let's see whether this balloon will cross. No problem. 16.
So all these tricks means we have done this all previously. So that's just experience, isn't it, George?
2,500 times.
Yeah.
16.
Yeah.
Down.
And then we learned, be careful at every step.
Yes, of course.
Because we know what's happening in the next step, so we have to prevent it before we go on. So.
Okay, down. I am confident to give some contrast antegrade, just for us to orientate, because we started late. And let me dear just a little bit this. There is a small piece of air here. That's good. I will give a little bit of a small puff there just to see if we can see any, to orientate ourselves in the direction of. That's what you see. It's true-to-true crossing, no doubt about that. That's why we give contrast. If you don't achieve that, then you don't. So, Dr. Gelev, what do you think? We should start stenting from this part down there that there is this occlusion. You see, that's going to be our target.
What about educational IVUS?
Educational IVUS. Educational IVUS. Dr. Gelev, can we do
education if you have a regular IVUS?
Yes, no, that's a good comment, Dr.
You understand me.
Yes, no, we understand you, but it's very essential. It's
we are preparing the IVUS.
It is essential for what reason?
The vessel is very big. Yes.
It will show us whether we were really true to true.
Yeah, he wants to confirm that.
The fact that the wire went all the way up, we know that in 25% of the cases when you're thinking with the IVUS studies that shows you think that you're true to true, but you are not. So,
guys, you have 33 minutes till the end of the session. So
it will not trade the strategy, but
feel it.
No, we have two reasons: just to see the
vessel
size,
advance a little bit more.
And the second thing is just to evaluate the ostium, because we are not sure where exactly we make the reconnection.
But it's a good point, Dr. Gelev, yes.
I mean, and we don't know the reconnection where it happens, whether
exactly.
Distal at the proximal cap, or maybe a little bit more.
No, thank you for this. We were rushing in our decision making. We were happy with our success, but the details and the specifics of the procedure will not be clarified until we have this IVUS. And of course, I have a 6-French guiding catheter. There is no damping. I don't know if you can see my pressures. Do you see the hemodynamics of the patient or not?
Yeah.
There is no, so this 6-French guide in the ostium is not causing any pressure drop. There is some backflow, but it's obvious that the ostium is also not normal, and this is a big vessel.
Absolutely.
Yeah, but we are sure that you were crossed true to true because you were already setting in the true lumen antegrately. So, and your wire passed as your guiding catheter was very deep in the proximal RCA. The second, going into the guiding catheter with your run through, it went smoothly. So you didn't hit anything there.
Yeah.
My concern about the IVUS in this case is just only because the distal diameter of the vessel, probably there is some aneurysm there. It looks like, and it would be useful for the stent
I don't know
sizing.
if you have any comments until now or something that needs to be discussed. For me, we followed the procedure in the way that it was most reasonable. We should not rush the retrograde, but we should also defer ourselves far away on the decision making from it. And this was a case that, to me at least, it was clearly after failing to puncture in a reasonable way. I don't say that if I have insisted another 45 minutes antegrade, I wouldn't have been punctured. Because you can take a dual lumen microcatheter, you can do many things more than we did antegrade. But when the collateral circulation is as good as this one, I think you should not refrain yourself from
Yeah, George, but it is still according to the book, you know.
I don't hear you well, sorry.
Yeah, it's still according to the book, so you are still inside the algorithm. So when we do CTOs, we want to be reproducible, you know. So from a teaching point of view,
yes.
And this is totally in the algorithm. So there is just ways of skimming the cat, and you have done a different thing from within the algorithm. So it's good, nice.
Okay, maybe a stent 40 to 48 millimeters will complete the case very well.
IVUS
or no IVUS?
IVUS or no IVUS?
No IVUS.
Do you open the IVUS? If you open
Yes,
it,
of course.
Yeah,
Okay, then IVUS.
Oh, then IVUS.
So, let's. I don't know how much time we have left, but let's do an IVUS.
You have 20 minutes.
You are so fast. We have a lot of time. You are so fast. We have a lot of time. 30 minutes.
Okay.
Maybe you can do another CTO in 30 minutes.
Yeah, we have another one, or he has also a circumflex.
Circumflex, yes, this is one that.
Yes.
So
yes.
you can place 40 to 48, and then go to the circumflex.
Let's do an IVUS, and we have one more case for your information, but we will do it on our own.
Just about having a talk, George. When I meant going antegrately, I didn't mean going antegrately. I mean just preparing antegrately, just for the sake of the discussion. So I totally appreciate. I would maybe do the same, but at least you had the feeling there. Sometimes you have the feeling the conquests were outside the vessel, and it's not. I'm doing that also many times because.
No, your comment was politically correct. For me, every time that I do an antegrade attempt, I consider it as a preparation for retrograde.
Yeah.
So it was politically correct, a comment. Simply, I didn't want to lose time on an antegrade without a retrograde marker.
Yeah, of
so
course.
That's why I wanted to have a wire, so I stopped giving contrast. And then you can do the antegrade part. Simply, it worked.
Yeah.
The chance it works is 25%. The rest, it doesn't. And we have done exactly what you suggested, but by having a marker wire, and then
but you crossed
then you don't give at least unnecessary contrast, because the procedure after retrograde wiring can be zero contrast.
But you crossed after antegrade Carlino.
Excuse me?
You crossed after antegrade Carlino. I'm just joking. You mean the contrast, you know.
Well, let's see what the IVUS will show as far as we have time for that.
So as George pointed out, he is totally right. Sometimes we do not, even if we want to antegrade, prepare the vessel, we don't know where to go. And sometimes you don't have the support to knuckle. And if you even scratch and go, and if you scratch with confianza, and then you don't know where to go, and you still need some guidance to knuckle down, okay? So that's then we go retro, as George has done it. But he didn't need any antegrade vessel preparation. He has done it retrogradely, and it was masterfully done.
Oh, we have those things together. Microcatheter is
So,
there.
but in that projection, he went into the aorta, and that time, maybe I wanted to, because now we know the course of the artery, and maybe I wanted to still try to knuckle down if I could.
You go ahead.
But he managed.
Can you see the IBUS?
Yes.
Okay, the vessel is enormous, as you can appreciate. This is, now we're in the occlusive part. And you see the hematoma from the antegrade at 3 o'clock. And we're completely true to true. The vessel proximally is around 4.5 to 5 millimeters. What I'm going to do, let's review this angiogram. And then, can you see the IBUS? You can, huh? Dr. Jeleva, why don't you make some measurements there to see the distal vessel, how big it is? Can we do?
Yes, it's huge vessel, by the way.
It's a huge vessel, as I told you, and that was part of our problem.
Yes.
This is the point that we want to use as a reference for stenting.
Maybe a distal part you can measure not media to media, but
So
woman,
what is it
woman
giving?
to woman, just
It's a 4.0 by 4.5 vessel, so a kind of a 4.0 stent and
4
post-dilatation
stent will be excellent.
So let's move a little bit more proximal. You see that it is diseased over there, a little bit more proximal. There we start at the distal cap. Let's go more proximal. We are all intima, no doubt. More proximal, it's all intimal. Clearly, and I will show you now, there is calcification at that point. I think we're still intimal. Here, stop here, please. What you see here, you clearly see the external elastic membrane here. We are intimal. And what do you see over there? This is the cloud of contrast from the antegrade wiring. So there is a hematoma outside the vessel from the Confianza Pro. But the rest, so we're completely, let's move on proximally. We're completely intimal, as you can appreciate here. So this is not the true lumen there. You can see that we're still true to true. That's branches. And a little bit more proximal. Let's make a measurement here to see the vessel. And I'm going to do an additional manual pull back to evaluate the ostium.
Exactly.
Because my guiding was sitting...
You see, that was educational, IVUS.
Yes. we wanted to avoid that, but yeah. 5 by 5.3. So, okay, what I'm going to do now, I'm going to disengage the amplats, and we don't, the good thing is that we don't have a problem.
The microcatheter.
It is okay, Dr. Gelev, but I'm going to retrieve the IVUS now a little bit as a thing. It will not be merging. There it is, okay. All right, let's evaluate. We don't need that much. I will do it manually for you. Yeah. Can we start?
We are recording.
Ah, you're recording. Okay. All right. Okay. No, I will do it manually. So I'm pulling back just to evaluate the ostium now.
Can we see the ostium?
Yeah, that's exactly what I want to do.
You're fine, guys.
It's a very, very diseased. Let's flash the catheter a little bit. It's a very diseased ostium. You will see it now.
We have.
There is a severe.
See the ostium there, eh?
Yes, there is severe stenosis.
I'm sorry that the catheter is jumping in and out because I took the amplats. Let me correct the guiding a little bit. If I correct the guiding, it will be more stable. Okay. Flash a little bit, please.
So what kind of IVUS is this? Is this still the assist?
It's assist.
Okay.
This is the assist, yes. Let's, can we get a little bit more image, Dr. Jeleva? I don't know why I lost the image there. The guiding is still in. We got the ostium for a certain period of time. Give me a little bit of contrast from the right side just to see where the guiding is sitting. Let's make a film also. There is no doubt that if you see it angiographically, that the ostium is subtotal.
Absolutely.
You can clearly show it also Eva there.
Yeah. The point is, Probably the size of the stent will be 4.0, but you should optimize
We
the
will
prox.
post-dilate with 5,
Yes,
the ostium.
yes, yes.
So, Dr. Gelev, do we have what kind of stent we want? You saw that I played the last angiogram for you. It will clarify to you the situation in the ostium. We can appreciate it there. Do you have the angio? Can you see the angiogram?
Yeah, we
Yeah,
can.
we are with you
Okay.
still.
You can clearly see that over there is a severe stenosis. So we will need 2 stents. We have to stent all the way to the ostium.
4/38.
4/38 for the distal part. And then we will take another 4 for the proximal and we'll post-dilate again. We might optimize that again with, should that be necessary, with 5.0 balloon. We'll do an IVUS for the best.
To follow the cliche, what kind of stent you will implant? I mean, what company? Science. Okay.
We need some advertisement here.
This is what I'm asking for.
Says the name of the stent.
Science.
Oh,
Great. Which type of science? Because there are a lot of them. Science
Just before Dr. Gelev, before you take the name, before you mention the name, let me cross.
Yes.
Okay.
So it is
Now-
clear that it is science.
Okay, otherwise it might have not been.
That was advertisement or?
From the right, always from the right. Give me a little bit, just give me a little bit of contrast. I will just go over there.
So this time.
Let's play the previous to see what are we going to stand.
so George, just from educational point of view, just to make some chit-chat. So when do you avoid antegrade giving contrast? You were sure here with the IVUS that you were true to true, and you are very free, liberal to give contrast. When you would avoid contrast giving antegradely?
I think you're
I'm sorry, we're focused contrast.
Okay, not important.
this.
Here. Okay, inflate. Say that again, please. I missed your.
Yeah, but it was not important to just fill in.
No, but it's
just
okay.
to fill the gap. So I was just asking, when do you avoid giving antegrade contrast? So you saw here that you were true to true from the IVUS, but is there any case you abstain from giving any kind of antegrade contrast?
The answer is always.
Yeah, but
Use the IVUS to make sure that you're not going to go the hydraulic dissection. So by giving contrast, I didn't do the very right thing, 16, 18, 10, 12. So this is a very important question, what you're asking, Shevket. And if we have to give a clear answer for the people of what to do and not to do, essentially you have to avoid antegrade contrast at any point of the procedure, except if you do an antegrade procedure and you are 10, 12. And then you're sure that you have done antegrade crossing from the very first moment.
yeah, but the problem is sometimes you don't get enough retrograde filling to see where to put the stent. That's a problem. And then if you don't have the IVUS and if you don't make the measurements, then it's a problem.
Then you have to use a little bit images, still images from the diagnostic, that they will orientate you into the direction of where you have to land. And sometimes you do that and you spend one more stent if you are not completely accurate, but you have to stabilize the lumen critically. Another more we need for yellow. So the answer is never. It's a compromise. To give antegrade contrast as I did now, it's a compromise.
So you did something wrong?
Yes.
Okay.
So
I did
now
that
the next
because I know
science.
that you're not going to say anything bad about me.
No.
Based on my history, otherwise,
of course.
You would have been criticizing me dramatically.
No. I was just filling the gap here. I need to say something.
Yes, please.
What is the next stent? Of course, it is science, but the length is 4.0.
Again, 38.
38.
38.
Sorry. We will need another one, as you understand. Okay, go 16. That was the proximal cap, or no, it was more proximal, down. And we will now, we pre-dilated the ostium, but let me just give you a little bit of contrast how much we will need there. Dr. Yelev, 20. Let's make a film just to having the balloon there. Yeah, something like
28.
28 might be longer, 24.
But this is
You see the stem? Okay. All right. Yes. Let's.
So maybe you can do the same thing here with a run-through wire into the aortic level.
Say it again.
Maybe you can do the same thing here to not miss the ostium with the wire, safety wire in the aortic root.
Yeah, we can do that, and we might need to do that. Although, no. That's a good point. Let's do that. We have a wire in the other system that we don't need anymore. We need it to retrieve the microcatheter completely, but we can take the run through from the left main and we can put it into this guiding. Thank you for that. Let's do that. Let's do that just for the demonstration purposes.
We are going to take another one.
That's okay. I removed the Dr. Geller.
So we have still time. You are not going to open the CX, so you should show us something. That's the point.
Who told you that we are not going to open?
Yes.
Okay.
The transmission time is quite expensive nowadays.
It's not necessary to be online. Patient first, always.
Okay.
So, no, to make the talking more concise, we discussed extensively with Dr. Gelev about the chances for the circumflex, and we both agree that this was not indicated at this time.
Yeah.
We'll see how the patient is going to be doing. Give me, Dr. Gelev, 40 by
28.
Yeah.
It is here.
Yeah, okay. Let's. Okay. Thank you, Shefket, for this comment.
Huh?
It's a good way to demonstrate this technique. And first of all, I'm placing the stent, then I retrieve the wire to the radiopack tip. This might avoid of giving you more contrast, more radiation, because usually we stent the ostia of the right coronary artery in degrees which are quite steep, 60 plus, 70 plus. Let's see how it will work now.
Should not stand exactly the ostium, and we should not protrude because the vessel is too big.
Yeah, let's take a 5.0 balloon, Dr. Gelev, no compliant, to post-dilate this stent. 5.0, it's very good because the vessel there is 5.3.
But it's on IVUS. If we reduce it by 0.5,
Okay.
let's do
4.5?
Yeah.
Okay.
4-5 балон дайте.
Valery, you measured that probably at that point it's...
Let's not finish with perforation.
So what? Oops. Oh, that's interesting, huh? You saw.
It happens, yes. But my point here is about why don't you try with something larger?
Let's make it
because I'm a little bit concerned about that 4.5
we need to go more prox.
will be not enough.
We will IVUS it and we will see.
Okay, okay.
Bill, that's we have the. I need to go there. What do you? No, it's too much. It doesn't help me much because. Let me just. Okay, I will. Now that I have the stiff part of the wire, I will put a marker to the wire point. You understand what I mean? That's the safest. This technique has this characteristic that you put a marker to the wire. Not give me contrast. What do you think about that? Okay, give some contrast now, just clarify whether this is correct.
Why don't you make a stand vis?
Yeah, it seems okay.
Because there is a wire.
Excellent.
I need to go a little bit more proximal in my view. I am better now. I will retrieve the guiding catheter a little bit more.
Yeah, but there is another trick. You can just inflate the stent with 2 atmosphere and then push the stent so you are exact at the orifice then.
Yeah, it's a good position too.
So it's sometimes very difficult to position the guiding catheter with the stent. So your position was excellent, but it was in the guiding catheter, your stent. So what I was suggesting was that we inflate the stent in the guiding catheter with 2 atmosphere and then pushing the stent so your guiding catheter is out and then you inflate further.
I always like the flaring down. So let's remove this wire anymore.
Is this aleocranial?
This is steep LAO, it's not cranial. I don't want, we open the 4.5 balloon.
Yes.
Okay, let's have this 4.5 balloon. I'm not going to do tracking of the guiding over the balloon. I'm just going to retrieve this and I will insert the guiding catheter into the stent after the post-dilatation.
And now post-dilatant IVUS.
Educational IVUS, education.
Okay.
Yeah, we have opened it already.
Yes. So we will see whether we were accurate enough to do that.
And then you will show us how you retrieve your microcatheter and your RGs free.
Yes. So let's inflate there, 10, 12. This is the proximal cap, 4.5, 14, down.
So this is the important trick here. George didn't push his guiding catheter, so he can maybe destroy the struts of the ostium. So he will do his post-dilation and then he will do it
down,
as he is doing it now by deflating the balloon and pushing the guiding catheter. So
you see that the guiding is already into the stent.
Yeah. So the
That's
ostium,
exactly
the struts of
we
the
were
ostium is
describing.
safe in this position. Yeah.
So we don't have any. Okay, big balloons. Let's de-air well, because sometimes there is. And let's see what we have achieved here.
Excellent result, as always.
Thank you. But there is a leak. You can see it, huh? There is a small leak in the junction between the two stents. We didn't go with a 4.5 balloon there. Can you see it?
Yeah, we see it.
I didn't see it.
So it's exactly at the point of...
yes, of the overlap.
Let's make a small injection there. Phil? Maybe not, maybe yes.
No. Maybe from a different position we can check.
Yes.
Sometimes it's happening from...
It looks like that there is something. What do you think, Dr. Gelev, there?
Let me see the previous.
The previous procedure, yeah.
Maybe from Areo.
There was a...
You mean from the junction of the two stents?
Branch.
There was a branch there. Let's see a little bit back just to evaluate what we have there. Because this is the 4.0 stent. Yeah, it is before. Let's see.
After you inflate...
yeah, let's see a little bit.
There was something...
Let's go before the stenting, just before we do that.
Because we have it here, but... Yeah.
We did the IVUS. Let's see what we had at this part of the procedure.
It looks the same, huh?
Looks the same, yes.
Yeah.
I don't know.
No, I'm pretty sure there is no leakage.
When you inflate the balloon, the 4.0 balloon, there was a staining, but I thought it was let's see.
Let's see a little bit. Let's make one more here, just make sure.
Yeah,
that,
from another projection, RAO maybe. No, there is no leakage.
I'm not sure.
So let's make an RAO, maybe to see the spilling.
Exactly, that's what I was going to do. I think that we have a type Alice 1, which is contained. That we don't want to leave any.
Maybe I'm looking at a different part. I don't know.
Okay. What do you think, Dr. Gelab? This is good here. Let's make one injection here.
I
Doesn't look
haven't
bad.
seen anything.
Let's go back to this initial one. Maybe we can do maybe it's a branch that it has been, which was the projection that we saw that?
Elio,
Maybe it's the compressed hematoma, because you see that there is some contrast there on top,
yes.
correct? Because the initial wire was very wrong. A little bit back, Dr. Gelab. You're looking the vessel before that. Here, it looks like there is a branch that goes down to. No, this is too early now. You see, this was the contrast that was existing from the undergrade wiring. There is contrast there, you can appreciate that.
Yes, there is a staining for
There is
sure.
a staining for sure, and it is exactly in the same projection. So maybe this is the part of the hematoma that we were saying, that there is still some feeling of it undergradely. There is no reason that there is no reason. There's always a reason that you have this kind of.
This is in the architecture, George. So
I know in the worst case scenario is type ALS1.
yeah.
Let's take another, Dr. Gelab. Let's see again a little bit what it is. We have to evaluate. Let me do an LAO-cranial, which I haven't done, just to see here.
But now we don't have any staining.
We will see. Let's evaluate that.
You see?
It is at the same point, maybe there is a knee at the proximal point and there is
Definitely
an overlap at that point.
So I can understand your concern. So I have done a lot of perforations, but here, I don't know.
Maybe LAO 60, pure LAO 60. I don't know what is this here.
Maybe you wait for 5 minutes and do the injection again.
No. This is type ALS1.
This is a branch.
But this is a branch. You see, this is branch.
This is a branch.
And you have some kind of a crater there, okay? It's opening, but it's not going, it's still in the architecture, I think. And it's not spilling into the pericardium. You have just a crater
No,
there.
it's obvious that there is no pericardial spilling.
Yeah.
We're just trying to evaluate what this branch is. I think it's a combination, potentially a branch in combination with the subintimal tracking of the confianza. What do you think, Dr. Gelab? What would be your positioning on that? Should we do an IVUS first of all to see what we see outside that, if there is anything? And let's do also a pericardial and transthoracic echo.
We're going to make an echo.
Yes.
And after that, we're going to evaluate.
Probably while you're waiting for echo, you can do IVUS just to be sure. And if the stent is well pulsed, you can just
put a balloon there.
Finish, yes, and
we cannot do IVUS.
Because something, probably we destroyed the catheter.
Yeah,
but we are going to take another one.
George, if you are worried, you can put a balloon there for 2 to 3 minutes.
No, that's what I was thinking of doing.
Yeah.
Let's do an echo. Let's do an echo on the patient. Anyway, we'll clarify here. it doesn't look like that it's going into the pericardium.
No.
It has the course of an branch. But anyway, we
just put a balloon there.
It is a concern.
Yeah. I totally agree with you.
The 4.5 balloon over there. The 4.5 balloon was clearly.
No, what we saw is when you inflate the balloon from the first stent that we employed,
it's an LS2,
staining or probably something that went into this direction, a branch or something else. This thing appeared during that time, but unfortunately we didn't saw it. We didn't.
Let's see. Here we have it already, Dr. Gelab.
Yes, we have it. You see. We have it after, even before putting the second stent.
Yeah, okay. We had it from the beginning.
No, before even.
Yeah.
Go back.
Yeah, it's there. Let's see here.
Here we have
I didn't give contrast. Yeah, but you see, yeah, exactly. You're saying the right thing. You see the contrast staying on top of it.
Yes, and it came as a hematoma or something was pushed. It is probably in
It is the hematoma that
in
we
this
see.
direction and dissected a vessel or maybe create some space.
I think this is related to the initial Confianza Pro pathway.
Guys, I think that this is a branch.
You can see that this contrast staining there is already there.
It follows and it courses like a branch.
It goes up to this very initial part of. So you see how complicated can be the antegrade tracking sometimes when the anatomy is really complex. Let me see a little bit where when I did the puncturing. You see, it's exactly at this point where the antegrade wire goes out.
Yes.
Anyway, we'll do an echo now. If we see that there is pericardial effusion, then we will clearly understand that there is a communication. If we don't see anything, zero, then we will know that this is not communicating with the pericardium because it is there some time as far as we're talking. So managing complications is far more complex than doing the CTO procedure per se, as you can imagine. And see how much nice discussion it has triggered. Nothing. There is nothing. So in that respect, anyway, I will tell you the following. And this is a very serious statement. And many times we have catheterized with Dr. Gelev hundreds of patients, I would say here. The decision making in this kind of thing has to be logical and always has to be done by the commander-in-chief. And in this place, Dr. Gelev is the one that he's going to face the patient at 3 o'clock in the morning should something happen. And this is very serious statement because I am hosting guest operators. Yeah. Every one of you is hosting guest operators, experts, no doubt about that. But at the bottom line, the consensus about that has to do with the opinion of the one that carries the final decision making. So I don't know, Valery, how do you judge this one? Should we do a balloon inflation there and wait? Should we do nothing? There is no pericardial effusion now.
There is no. We are going to
consider that as a deal done.
No, we have the sheets in place. I mean, the femur, if necessary,
we will come back.
We will come. We will have balloons. We have cover stands.
Okay, but at this time point, the decision is to stay. Okay.
Let's make another film. Yeah. And maybe when we remove the gears from the.
Let's remove the left system and the gears, and we can always have good access there. Let's show how we will do that.
We can put the antegrade guide wire, but this is.
It is stable. It is stable there. It is stable.
It's LS2 actually. I think.
Give me again the run through. So let's focus a little bit. Let's move on. I will remove the retrograde things. The guiding catheter, the antegrade guide is sitting perfectly there. There is no any problem of accessing antegradely. Let's remove the retrograde and show how we would do that. And then we will reevaluate that again because removing the retrograde gears, it is still a process. I will reinsert the wire that I had before to avoid any left main deep engagement and potential dissections. Okay, you see it there. Okay. And now, one thing, already my retrograde microcatheter is a little bit deep into the septal part. So what I'm going to do is that I'm going to retrieve it by keeping the retrograde wire. We're going to make a tip injection there. You see it, I do it by rotation. I don't force the guiding catheter, the antegrade remains stable. We just want to control the collateral. Be careful at this time point that you don't take back your retrograde wire because you can slice the septum. I think that's enough. Let me insert a little bit the guiding. Let's make a film from the left system, just control the collateral. There is no issue there. We reinsert the microcatheter. And then we retrieve the retrograde wire. During that, you'll see that the antegrade guiding is going, the microcatheter might jump in. Here we have zero resistance. When we see the radiopack tip, it's there. Then we will retrieve both of these together to avoid any tension in the collateral, as you will appreciate there. Okay, that's good. I should have kept one wire in because I don't have any, the guiding is not engaged, but I feel comfortable. Give me a little bit of contrast for the left vein, please. I think we are okay.
Yeah.
I will retrieve this this guiding catheter. So that was how you do it. You check the collateral, you reinsert the microcatheter, and then you retrieve the material and you remove the retrograde guide.
So we have 1 more minute.
Yeah, let's make one final. I think we finished here. I think the situation remains stable. There is no pericardial effusion. In my view, we can consider that as a successful procedure and uncomplicated, always having the caveat. The standing in the ostium is very good. You can see clearly that we covered the ostium. There is a good backflow. It's not too out, it's not too in. Any comments from your side? We're happy with this. We agree, both me and Dr. Gelaf, that we should do nothing.
Congratulations.
At this end, but watchful waiting.
Yes.
Yeah.
You have
Again,
sheets.
I have to thank you for having me here for one more time in Bulgaria and participating in the meeting.
It is our privilege, George.
Always a great pleasure and honor to be among friends. Thank you so much indeed. Thank you.
Thank you.
Dr. Dobrin, thank you, Dr. Gelaf. Thank you.
Thank you.